In this presentation, I'm going to be demonstrating how to give medications down a feeding tube. And in this case, we're working with a CORPAK. Let me just set up the situation first before I get started. This is Duke Blue Devil, my patient, and he's receiving tube feeding. And it's going at a continuous rate through his CORPAK that is in the stomach. So I do have the opportunity to check gastric residual volume, GRV, because the tube is in the stomach. We'll presume that he's in the midst of having his tube feeding titrated up. It was just started last night when he had KUB confirmation of his tube placement, and so we're still kind of titrating up and trying to get to our goal of 70 milliliters per hour. Every 4 hours I need to check GRV in order to assess tube feeding tolerance along with other parameters for tolerance. And in this hour, he is due for his GRV to be checked, but he is also due for some meds. So I'm going to coordinate those two together. So I will begin by going to the med room and getting the medications that he needs. Okay, so now in the med room, I'm going to pull up Duke Blue Devil's EMAR. And I'm going to pull out his meds, and based on my review of the chart before or at the beginning of my shift, I know that I have 2 medicines to give him at this hour. One is a multivitamin, so I will go ahead and perform check 1. And the next one is a liquid. This is lactulose, and again, I'm going to check it up against the EMAR, and that satisfies check 1. Now, at this juncture, my preparation in the NRL hospital is done at the bedside, and each patient has his or her own pill crusher, so I can do everything I need to do at bedside, but I need to think about supplies. What supplies are in the room, and what supplies do I need to take with me? So I need a couple of cups here. I will need to do some med math as well, because I have to determine how much of this oral solution I will need. If I need a volume that is less than 10, I will need an oral syringe. So I would calculate my med math. In this instance, I need a volume of 30 milliliters, so no need for an oral syringe. So I'm just going to grab some cups here. I have a couple different varieties, so you can choose the one that you like best. And then I am going to be sure that I have something to stir in order to mix these, and that should do it. So I'm going to enter the patient's room, and I'll put my medicines down for right now because I have to check my tube and my tube feeding first. I'm washing my hands. Hello, Mr. Blue Devil. I have some medicines for you this morning. And I also have to check out your tube and your tube feeding, make sure everything's going well in that regard. First things first, can you please state your name and date of birth for me? And he says his name and date of birth. I pull up the chart. I check to make sure that this is indeed Mr. Blue Devil. Everything matches up. Anticipating my meds, I'm going to go ahead and ask him for allergies at this point. Please confirm your allergies for me. He says I have no known allergies, and that is consistent with my chart. Okay, so first I have to check out the tube before I move forward. I am going to start by checking placement. So with tube feeding in progress like this, I do not have to worry about pH because the tube feeding formula buffers the pH, and that's not a valuable marker anymore in the presence of tube feeding. So what do I have left to work with? I'm looking at external appearance, so I'll go ahead and put some gloves on at this point. And I'll make sure that my marker is where I expect it to be based on my documentation. All right, that looks good. And then I'm going to go ahead and put my tube feeding on hold. And I'm going to get ready to pull back some aspirate. My aspirate will kind of look like curdled tube feeding. I might see a little presence of gastric contents in there, but predominantly what I'm going to see is tube feeding. So I'm going to go ahead and disconnect, plug it up. I have put my cap in reserve here, so I'm going to cap that, keep it nice and clean. And now I need to aspirate the gastric contents. I'm going to take a look at it, and I'm also checking volume to see if he's tolerating his tube feeding, to see if his stomach is moving things forward, just to make sure that he doesn't have any signs of delayed gastric emptying. Aspirating from a quart pack is a little more difficult. We have to make sure that we always start with air. So I'm going to put a 30 milliliter bolus of air in first, and then I'm going to pull back very gently. And that will prevent the tube from collapsing, and it'll allow me to pull back aspirate from the stomach. All right, so pulling back, I see the tube feeding formula, and I have filled my syringe. I have a nice clean graduate container, so I'm going to transfer this volume to my graduate container and then continue aspirating. All right, so we aspirate till we cannot pull anything further. So that looks like I have emptied the stomach at that point. I'm going to go ahead, clamp it up for a minute. I'll need 2 hands. And I see that I have 90 milliliters. My parameter is anything less than 250 is okay. So it looks like things are moving along just fine in the GI tract. So I can go ahead and give this back so that I don't cause fluid and electrolyte imbalance. And for that, I'm going to funnel it in. We can unpin it just to give ourselves a little more latitude. So we'll let that go. We'll try to prevent getting gaps of air in between the liquid, just for patient comfort. It's a good idea to hold the connection so it doesn't come apart. When it gets down into the tip, we're going to go ahead, lower it and clamp, and then I always want to follow this with a flush of water. I'm starting out with 250 milliliters of water, but my flush here is only 30 milliliters, and I'll use the markings right on the syringe to measure. And I'll let that run through. And now I know that my placement is unchanged, my GRV is good to go. So I'm going to go ahead now and prep my meds. Okay? Okay, so moving over here, I'm going to have a glove change, and I am going to wash my hands because I want to kind of moving from a little bit more of a dirty procedure to a clean procedure. So for infection control principles, when I switch from checking GRV and so on to prepping my meds or preparing tube feeding, I always want to insert a glove change hand wash. Okay, so I have my medications that I have to give, so let's get back into medication administration mode. I'm going to pull up the EMAR, and I am going to do check number 2. So I'm checking these along the EMAR. I note the right patient, drug, dose, route, time, reason. And I would do that for both of them. Drug, dose, route, time, reason. So that is check number 2. I've also done my homework, and I know that my pill can be crushed without a problem. It is not on the do not crush list, and the lactulose is already in liquid form. Also, I need to think about pre-administration assessments such as blood pressure, pulse, those kinds of things, and there are really none that apply here. So then I am going to go ahead and I am going to do check number 3. And the reason I have to do all 3 checks before I start prepping is because I need to scan this barcode. So let me go ahead and just check it again, check number 3. I am going to hit administer. At this point, I would go ahead and I would scan the patient's barcode, his wristband, and then I'm going to go ahead and scan my first med. Okay, so check 3 and then scan it in, and then I'm going to go ahead and prep this. Okay, I have the patient's designated pill crusher here. It's nice and clean. I could clean it with an alcohol pad if I need to. And then I'm going to go ahead and just drop this in. And then turn it into a fine powder. This particular feeding tube clogs very easily, so we have to be careful that we mix it well. And then I'm going to transfer the powder to a cup. Now I could use this cup. Actually, this cup is nice to use as well because it's a little bigger, gives me more opportunity to stir. And then I'm going to use tepid water. I'm going to pour it in maybe about 20 mils, and then I'll top off to a total of 30 milliliters. So I want to mix each med with 30 milliliters unless I have some kind of fluid restriction, in which case I could probably get away with a little less. All right, but 30 milliliters is a good volume to make sure that this is not too chalky, so that it does not occlude the tube. All right, so I'm going to pour off the rest for a total of approximately 30. Okay, and then I'm going to make sure that this is neatly placed on my overbed table using the wrapper to label it. All right. So the next medication is my lactulose, and I'm going to go ahead and do check number 3 on my lactulose. And then I'm going to scan it in. Okay, I have 10 grams per 15, and I have a 30 gram dose. Based on my med math, I know that I need 45 milliliters for my 30 gram dose. I'm going to make sure I use a nice clean cup. I'm not going to use the one that I put the GRV in. And so actually this one doesn't have the exact marking that I need, so I'm going to use a combination of these two. I'll put 30 in one and 15 in the other. Palm the label and pour at eye level. All right, so moment of pause. Make sure that I have done all of my safety checks and balances. I checked the position of the tube. I checked GRV. I gave the GRV back. I followed with flush. I checked patient identifiers. I confirmed allergies. I checked each medication against the EMAR 3 times, and I scanned them all in. I also scanned the wristband. I thought about pre-administration assessments, and I also know that there was no problem in crushing these meds. So with that, I'm ready to go ahead and proceed. So all of the prep is done. I can focus on administration. So I'm going to move this just a little closer. And I'm going to set up my funnel. Make sure it's seated in there really well. And this one is it's just telling me it's been on hold for a long time, so I'll just press hold again, buy me a little more time. I gave my pre-flush already, so I'm going to go ahead and I'm going to start with my multivitamin. If I have a lot of residual medicine in the cup, I'm going to go ahead and pour a little extra water in there give it a stir, just try to pick up as much as I can, pour it down, and then let it drain by gravity. When it gets to the tip, I'm going to drop and pinch it, and then I'm going to give an in-between flush of 15 to 30 milliliters. So just use your nursing judgment as to what end of the range you want to be at. So let that go, and then I'm going to go ahead and give my lactulose now. Lactulose in the clinical setting is pretty thick, so we could always add a little water to it, or at any point if we need to use our plunger to help it go down, we can do that too. Okay, now it's in the tip. This was my last medicine, and because as I said, it was pretty thick, the lactulose, my post flush is between 30 to 60. And so based on what I just gave the patient, it would make sense for me to give closer to 60 to make sure that the medicine was rinsed down well, and so we don't run into problems with the tube occluding. So I'll let that go down. Okay, that's my post flush. And then I have to think about this tube feeding here. Now that my meds are in and everything is flushed, remember my protocol. I'm going to increase by 10 based on tolerance. I know that my GRV is low. That's a good thing. Patient's not distended. Think about all of the parameters for tube feeding tolerance: abdominal distension, nausea, vomiting, liquid stools greater than 3 in a 24-hour period. Changes in bowel sound, so I'm looking for all of those things. Along with my GRV, all is well. I would add more tube feeding as needed, and then I would go ahead and bump up my rate to 50, because remember, we're going up incrementally as tolerated. And then I would go ahead, and I'm going to put some new gloves on here and attach it back to the patient. If needed, I could go ahead. Always a good idea to go ahead and decontaminate the end of my feeding tube before I make the attachment. Make sure that the head of the bed is at least 45 degrees, which it is, and then clean up. Put my patient in a position of comfort and safety. I could also clean out this pill crusher and have it ready for the next time we need it. So this concludes my demonstration.